Good morning, everybody. Welcome to Pink's Lecture 2019. All right, so I thought I would try something a little bit different this year, whereby I invited you who are going to be attending in giving me questions to answer, because certainly when I see people every single day, there's always a lot of questions. You're very inquisitive. So I thought that a Q&A session might be a bit of a slightly different approach to this. However, I've either given you too good a lecture in the last 10 years because you don't have anything that you don't know about, but I only got one question. So in response to that, I'm thinking that you're all too shy and that you might need a little bit of prompting from information I'm going to give you today for you to lead to giving me some questions. So I really like these sessions to be interactive. I don't want to be talking at you. I don't want to be saying things that aren't clear. But what I think I might do is give you an update on all the things I'm going to talk about, and then we'll reserve the questions all in one hit at the end. Now, can I just say to you, not as a threat, but as just a comment, if no one asks me questions, I'm going to ask you questions. And I know enough of you in the audience to know who to pick on. All right, so what I thought I would do this year, which is sort of a bit basic, but I thought in conversation every day, I find that there is still a little bit of uncertainty and lack of clarity into certain definitions we use in cancer, but particularly in breast cancer. So I thought I'd just give you a run through on that. Then I thought I'd give you a nice, I hope, detailed account of how I, as an oncologist, and how we as breast cancer specialists approach the way of managing patients with metastatic breast cancer, and things that I think you guys need to know about. And as I said to you in all the previous years that I've given these talks, I really hope you share what you hear today with people in your family, in your community, because I'm hoping that you will be the ambassadors for BCRCWA to actually write the incorrect information that's out there in the community and provide a greater sense of understanding for this disease in the community. And then those are the topics I've decided to talk about, given that you didn't send me any questions. So I'm going to talk to you about how to treat breast cancer. I'm going to talk about new drugs. I know that there's an interest in what the new treatment is. I'm going to focus it basically on a family of drugs which I think personally will make a big difference in the lives of many women with and men with metastatic breast cancer. I've also decided to talk about blood tests for cancer because I know it's been in the press in the last 12 months. Research showing that you can now measure cancer levels, you can use it for all sorts of therapeutic interventions. So I'm going to give you a little talk about that. Then I'm going to give you an update about some interesting studies which I think is going to actually impact on the community, certainly here in WA, if not throughout the world, Australia, from some studies that we've been conducting within our group. And then I'm going to give you the frequently asked questions that I get given. And if all of you know the answers to it, just wave me through, okay? I'll just bypass it. Okay, so basics. When we talk about metastatic cancer, and so these definitions essentially do apply to a lot of other cancers, but specifically this is the truth about breast cancer. Metastatic breast cancer is synonymous with the term advanced breast cancer or stage 4 breast cancer, all right? Now, some of you may or may not have had or been told about a condition called locally advanced breast cancer. That is not metastatic. Metastatic means it's traveled further afield than the breast and the underarm lymph nodes. Anything that goes beyond that is then metastatic. So a patient with locally advanced breast cancer has cancer in the breast, but it is so large, it is so involving the skin or the muscle, it's so involving the lymph glands under the armpit that we actually give it a special name called locally advanced. There are some women who have locally advanced breast cancer as well as metastatic disease elsewhere, but there are also a large proportion of women who have locally advanced breast cancer, but they don't have metastatic disease. And by definition, locally advanced breast cancer without metastatic disease elsewhere is called stage 3 breast cancer. Terms that we as doctors use are metastases, exactly the same meaning as secondaries or secondary cancer. So for a woman with breast cancer where it's spread into the bones, we don't call that woman bone cancer. She doesn't suffer from bone cancer. She suffers from bone metastases from breast cancer, bone secondaries from breast cancer, or secondary cancer of breast in the bones. Okay, so when you're reading articles or discussing sort of things with people who've got disease in the bone, it's very important to clarify whether they've got secondary cancer from somewhere else in the body that traveled to the bones, or they have primary bone cancer, which is a completely different condition altogether. All right, so in primary bone cancer, the cancer starts in the bone, commonly in your leg bone or your pelvis or in your arm, and it's a completely different condition, treated completely differently. Okay, terms that I use, and I know many of my colleagues use, which sometimes get a bit confused, is all these terms are exactly the same. So when we talk about lesions, spots, masses, shadows, or lumps, they're all the same thing. One is not worse than the other, all right? And what it is, it's a description. It's a description that we use to communicate amongst ourselves and to our patients that there is something abnormal showing up either on a CT scan, an ultrasound scan, an X-ray, a PET scan, or a physical examination. So if I find something in someone's neck, I'll say, oh, you've got a lump here. Now, if I use that term, it's just a descriptive term. In someone who has metastatic breast cancer, obviously, the first thing you worry about is that lesion, spot, mass, shadow, lump, is it a secondary cancer or is it something else? So it doesn't necessarily mean if people use the term lump or masses that it actually means cancer. It could be, but it could just be a shadow or an abnormality that subsequent testing and so forth shows that it's just a benign fibroma or a benign lipoma or a pimple or an abscess or something else. All right? So please don't be scared or distressed if those kind of terms come up in conversation, which I've seen ladies, the minute, the word lesion is mentioned in a CT scan report or in conversation, there's a lot of fear engendered, but it doesn't necessarily mean that. I'm trying very hard to give you a mental picture of what cancer looks like. So I'm going to go through a few slides just to show. So this is a color electron microscopy of what a cancer cell looks like. And this is actually a breast cancer cell. So the abnormality is this little thing here. In comparison, these little red things at the back are red blood cells in your bloodstream. So you can see a breast cancer cell is much bigger. It has all these tendrils coming out of it, and it's got quite a different surface to it. And if you look at the sort of finer detail of that, it's because on the surface of breast cancer cells, there's a whole lot of extra protein gunk. Some of it's important, some of it isn't important. To put this into perspective, that red dot on the screen measures 1 centimetre. And in that spot, there are at least 100 million breast cancer cells. So when you think about, does cancer show up? What does the scan mean? If the report says the spot in the lung is the same size or it's a little bit bigger, you've got to try and think at this level. If cancer cell numbers are changing within 1 million to 10 million, you're probably not going to pick it up. Once it starts diminishing by more than 100 million cells or increasing by more than 100 million cells in the same area, then you might have the possibility of picking up a difference. So often when ladies have had early breast cancer and they finish their treatment, they'll often ask me, okay, so what kind of tests am I going to have on a regular basis to show whether my cancer is coming back? To date, there are no tests or scans or blood specimens that will pick up cancers unless there's a lot of them. So the current recommendation is you do not do regular blood tests or scans for early breast cancer patients. And that's the rationale. It's not because we don't care, but we just don't have the medical level of accuracy to be able to pick up these things. This is a picture of a cancer cell next to a normal cell under a normal microscope. So on your left, this is a picture of a normal breast cell, okay? So all this is the protein and other factors that exist within the cell. And in the middle of the cell, there's a different area. You can see it's a completely different color, where the constituents of this is different. And this is where the nucleus sits. And the nucleus is the powerhouse of every single cell in your body. So it's no different in a breast cell. When that cell decides to become cancer, it then starts looking like this. And you can obviously see the clear differences. It's now no longer round, it's all a bit pickledy. You've got these extra clear bits in the cell. The nucleus, compared to this one, which is normal, look how much there is. So this is all the DNA material driving this cancer cell. So visually, breast cancer cells are different, and functionally they are different because they start containing a whole lot of different things. And this is the baseline of why, when we look at treatment, drug treatments and so forth, it is such a completely different animal to treat than other cells. Because you're trying to break through an abnormal-looking cell which has different kind of constituents within the cell itself. You've got all this genetic material driving your cancer, and you've got to be able to switch that off to successfully kill that cell. And in metastatic disease, you've got to do that in every single cell that exists in that woman's lung or liver or so forth. So that's the challenge. Not impossible, I believe, but that's the challenge. And that dot is let's just under one, is 1 point on the screen. A cancer cell, the one I've just shown you up here, in real life is 1/100th the size of that dot. Okay? So when you ask, can we pick it up in the bloodstream? Is it showing up elsewhere? That's the challenge. Can you imagine trying to have a technology that can pick up a single thing that is 1/100th the size of that dot? Okay, 101, cancer development. In this top picture is what a normal cell looks like. It's round, it's clean, and it increases, it doubles, because you have to. If hair's going to grow, your hair cells have got to double. If your skin's going to repair after a scar, it's got to double. So that's what normal cells do. When they're doubling, they're growing. When they have a damage to it, right, and the damage is so great, the normal cell suicides because it says, I can't repair myself, I've been damaged too much, and it dies. And that process is called apoptosis. Okay, so that's the simple discussion about what a normal cell does. When a single cell, and in this context we're talking about breast cancer, when a single cell in the breast turns into cancer, first of all, the DNA mutates. And it mutates in such a fashion that often translates into that cell increasing its growth rate and cell division very quickly. As it grows to slightly more cells, there are more mutations that occur, and more mutations, and more mutations. When it hits a critical point of a mutation where the cancer cell is actually just now running on its own accord, it becomes uncontrolled growth. And that, by definition, is a malignancy. So that's the basic premise of what cancer does. And then all the ongoing problems is what happens to that mass of uncontrolled growth cells. And in metastatic disease, this is just a simple picture. You've got a mass of cells, these are now cancer cells. What they do, because they're really smart little things, is that they grow their own blood vessels, all right? And these blood vessels are really abnormal looking. If you look at it under a microscope, they're bizarre, they don't look nice, they are sort of a whole lot of little tendrils coming out. But the cancer cells like it because these blood vessels supply them with the nutrients that they want. These cells, as they grow and progress, then become sort of have the ability to move around. And they move around by invading outside the blood vessel, forming little clumps within the blood vessels. And then when they've formed enough of a big clump in the blood vessel, and let's just take, for example, this cancer has traveled to the lungs, it actually invades. It comes out of the blood vessel and gets into the space around itself in the lung. It then continues to keep on growing and breaking out, and then it starts moving to other places because your blood vessels are all connected. And that's how the whole process continues. And that's how one cell started off in the breast can ultimately travel to one spot in the lung and multiple spots in the lungs. And this is going to apply to every single organ in your body. So that's my basic 101 on breast cancer. Now, as I said, I'd rather you think about that and tell me if there's anything that's not clear or you want to question me on, and hopefully you'll remember to ask me at the end of the meeting. Okay, so now what I'm going to do is, I guess, talk to you as a group to say, what is the general approach to treating breast cancer? because hopefully this will give you a little bit of understanding of what is recommended for you guys. And when you speak to other, patients who have breast cancer, and you notice that there are some similarities and there's some differences, hopefully the next few slides is going to help you understand why there are those differences between seemingly the same condition in two of you, but you've managed being a little bit different. But I'm going to give you the basic principles. So without making it too simple, the first thing to say when you're diagnosing breast cancer or any cancer is make the diagnosis. You will be, I don't know whether you'll be surprised, but there are case reports of cancer cures in individuals who had a lump, lesion, shadow, mass found, never confirmed as cancer, but diagnosed as cancer, given a treatment, the lump mass lesion disappeared, and the conclusion is cancer cure. And I tell you, this is not a rarity. If you look at reports and stories and not in published evidence, that's the detail that's given for saying that diet or that intervention cured the patient. So if you want to look at any stories, the first question you should ask when you're talking to someone or you read an article is, was the diagnosis confirmed? And how was it confirmed? Was it confirmed because the doctor said you've got a lump in your lung, it's cancer? Or was it confirmed because they found a lump in the cancer, they put a needle into it, took it out, sent it to the lab, examined under the microscope, pathologist said this is not lung tissue, it's lung cancer? That's confirmatory, all right? So it's really important. It sounds really basic, but it's really, really important. For breast cancer, it's really important to know what kind of breast cancer it is, because I think, as I've said every single year in all my previous talks, breast cancer is not one single condition. Many of you in the audience knows some women have HER2-positive breast cancer, some women have triple-negative breast cancer, some women have estrogen-positive breast cancer. They're all breast cancers, but they all have different prognoses, they all have slightly different treatments, they have different outcomes, different response rates. So if you're comparing stories or looking at an article to sort of see, does this apply to me? You've got to ask, which kind of subtype of breast cancer are they talking about? And it's really important to do that before you sort of take any of those points home. The next thing we do as doctors, once we've confirmed it is breast cancer, is to clarify the extent of the cancer. So even though a lot of times there is a bit of a disinclination to have radiation exposure to do scans, in 2019, the only way you can accurately define what the extent of the cancer is by a series of blood tests, scans, and physical examination. And I might make that a big point because I still see some women who had treatment elsewhere and in other times where they don't actually get their cancer examined frequently enough to know what's happening. And that's an important, simple thing that doctors can do. So once you clarify the extent of the cancer, then, as I said on my first slide, a woman is defined as metastatic stage 4 cancer when she has been confirmed as having breast cancer, and all the tests that have been done shows that there is evidence of cancer outside the breast and the lymph glands under the arms and the lymph glands up in the neck. Once it goes beyond that, by definition, it's metastatic cancer. The next question we ask as doctors before we start treatment is it in a dangerous part of the body? Because this makes a big difference. So for argument's sake, you could have a woman who has been confirmed as metastatic breast cancer, and the scans show there are about 5 spots in the lungs, 4 spots in the liver, and a couple of spots in the bones. Now, to you, you probably think, oh, poor patient. I mean, she's got a lot of disease. Yes, she's got cancer in 3 different spots. But can I tell you that that woman is in a better position than another woman who has one single lesion in the part of the liver that supplies the liver's elimination process and goes into liver failure. So it's not just where the cancer is, it's how much is it, and is it near something that is a danger to the body. Another area which you'd be aware of is if it's in the brain. So you could have a woman with one lesion in the brain. It could be relatively safe, because it's in a safe part of the brain. It's not going to cause anything except for maybe a bit of mild headache. Or you could have a woman who has one lesion, which is 1/10 the size of that first woman, but it's in that part of the brain that blocks the brain fluid system. That will make her collapse and at risk of dying. So the position of the cancer is really, really important to ascertain. Right? And often when you're sharing stories or hearing stories or reading articles, you don't get that kind of detail. So when you sort of say, wow, she had really bad cancer because it was in the lung, the liver, and the bones, and, what she did has improved things, well, that's a good story, but you also need to know how dangerous that part of the body the cancer was involving is. The next part is how healthy are your vital organs and how good is your general health. And this is something, obviously, that as individuals, we all have control of to a degree up until the time that you get diagnosed with the cancer. And so that point of your health when you're diagnosed with metastatic cancer is really, really important in terms of doctors making decisions about what treatment you have. Because if you have diabetes, uncontrolled high blood pressure, repeated urinary tract infections, abscesses in your bottom or hemorrhoids that you have problems with, which is significant, all these factors need to be taken into account before a treatment is recommended. Because otherwise, if you don't take into account all those other health issues, you could actually endanger that person's life by not taking into account those other factors. Then the other things is just background important knowledge of coexisting problems. So, it's always important to tell your doctors if you have had a serious illness in the past. Now, I don't see this happening, I don't think I've ever seen this happening, but it's really important. If you've had HIV infections in the past, if you've had hepatitis B infections in the past, if you have had a potential life-threatening allergy to a drug or an agent in the past, it's really important to give that information up. Now, most times you get asked about it, but sometimes, it may not come through because you're discussing so many other things. So, in your own health, what has happened to you in the past. So it's important to be very open and transparent with what you tell your treating doctors. And then the last thing is coexisting medications. And when I say medication, this includes supplements, alternatives, other goodies that you guys might be taking. And this is really important. I'll come to this a little bit later on. But the importance is that if you are taking something, even if it's natural, it may have an interaction with your cancer treatment. So, never be frightened to bring out all your bottles. And that's what I ask you guys to do, is don't expect you to remember what the constituents is of the 20 things that you take. So just bring your bottles so that, I can have a look at it and let your doctor know what you're taking. And it's really important to be honest. So I know that some patients think that intravenous vitamin C is good. Some people use medicinal cannabis. Other people use all sorts of enemas and trochas. Not a lot of science to it, and I'm not going to spend a lot of time talking about alternative therapies today, unless you want me to. But it's really important to be upfront, because you don't want to jeopardize your health by being put on a treatment that could interact with some of these other things that you're on. And then clearly, whatever medicines you're taking, it's important to tell your treating doctor what that is. Now, this may all seem really basic to you, but this is really crucial in how I make decisions about how to treat women and men with breast cancer. And the first and foremost thing is choose the best treatment based on evidence. So I don't think I ever, pull out a paper, pull up some graphs and show people, this is the data that supports drug A that I'm going to give you. Because I've already done all that for you. I already know it, I read it, I've congested it, and I've decided what is the best evidence for you. But I can't impress upon you how much time, money, and effort is made by all sorts of people in the health industry, not the least of whom are patients before you, to contribute to the findings of which drugs are the best, which surgery is the best, which radiation approach is the best to treat you. So always, without a fail, when I'm recommending treatment, you'd recommend the best treatment up front. You don't save your best till last, as a few people sometimes ask me. You give the best up front. You give it based on the evidence of the day. So it's really important that, you keep up to date with all the research that's coming through. And you apply it to that woman, because you have made the decision that she fits in that same population of women that were treated in the setting that identified the best treatment. And so you're expecting that she will have as good a result as those women and men did in those trials. Now, sometimes when you are first diagnosed with metastatic breast cancer, the best treatment for you might actually be to consider involvement in a clinical trial, not using you as guinea pigs in any way. And I think one of the things that's most reassuring is that breast cancer is the one cancer disease that has the most treatment options available, right? But it also is the cancer that has the most progressive development of new and better drugs. So if I or any oncologist recommend for you to consider a clinical trial, it's because in their assessment, the treatment you might be able to receive in the trial, and I'll come to placebos and randomization, all that in a minute, is potentially the best treatment for you. And I can see people in the room that I know are a testament to it. Your involvement in the trial has actually led to the outcomes that have been so good for you guys. And so you've got to understand that not all clinical trials are experimental. So there are some trials where every woman that goes in the trial gets the active treatment. So obviously that's very attractive. There are some trials where you go into it and it's a flip of a metaphorical coin done in a computer program, usually in Europe or in America, that selects in an unbiased fashion whether you get the best current treatment or the new treatment. And in some of those trials, to provide the scientific robustness of that trial, the women who are allocated to the best standard treatment get a placebo. So everybody in the trial, including your treating doctor, doesn't know whether you're getting the real treatment or not. All right? And if you've got questions about that, is that ethical? Why do they do that? I'll answer that for you at the end. So once you've decided on what the best treatment is, the next step is to evaluate that it's working. Now, this may all seem really, really basic to you, but can I say that when I lecture trainees and residents, it's actually kind of refreshing to know that they don't actually know that that's how you treat cancer. So when you're treating a metastatic patient, you've chosen the best drug, you want to make sure it's working. Now, how you do that depends on a few things. One is your knowledge of how quickly you think that treatment's going to work, right? Secondly is where the cancer is in that given woman, do you expect to be able to see a response quickly or not? And thirdly, where the cancer is in that woman, how are you going to tell whether it's cancer getting worse or healing going on? All right? And I know for many of you have had these kind of discussions already. So that comes down to knowledge and experience, but essentially what you want to do is, having identified where the cancer was originally with whichever scan, you use the best scan that gave you the best pictures again. Now that sort of makes sense, doesn't it? And again, it often makes sense to do it at the same practice, with the same machine, with the same reporters. I mean, that just makes common sense. So sometimes, for convenience, some ladies will say, well, can I go close by? And I often say, look, it's worth the effort to go further afield to where you had your scans first, because number one, I trust those radiologists. Number two, it's the same machines, and I know it's going to show sort of more equivalence than a different machine with different settings and so forth. The second thing is you've got to decide which part of the body where the secondary cancers are that you expect to show you whether things are working or not. So by this, I mean women who have metastatic bone disease, often this is the hardest area to assess whether things are getting clearly better or clearly worse. The second point is that in most instances, the response of breast cancer in the bones is often slower than in other areas of the body, like the liver or the lymph glands or the lungs. So often when I'm doing follow-up scans, unless it's in a clinical trial where it says you have to do these kind of scans at these kind of weeks, I generally would do the best scan or scans I think necessary, usually within about 9 to 12 to 15 weeks of starting a new treatment. Because at that point, I've given enough time for the drugs to work, and I'm expecting to be able to tell whether it's a good result or a bad result. Now, in some women, they actually have lumps that they can see and feel, and I can see and feel. So if those exist, I use that a bit once I start a new treatment to see whether things are working. And then our job is to put all that information together, as well as your blood test and tumor marker, which I'm not going to talk about today, and with the scans and as well as how you're feeling and your other blood results, like your liver function, your kidney function, all the rest of it, we make a conclusion at that first point of evaluation. Is it clearly working? Is it all fabulous news? Is everything stable? And I'll talk about this more later, but stable is great news, or is it getting worse? Alongside all this treatment, you want to minimize side effects. Now, I've got to be honest, I can't get rid of every single side effect from treatment, and you know that better than I do. But it's really an important thing which I teach juniors, to minimize side effects, knowing what the side effects of the drugs are, because you know the evidence base for why you're using that drug, and trying to prevent it. Prevention is always better than curing it. So if you know the drug is going to cause constipation, try and get patients to use laxatives preventatively. If it's going to cause nausea and vomiting, blah, 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 blah. So prevention is always important. And alongside, in parallel with minimizing side effects, is giving advice and encouragement to try and maximize normal life. So while you're starting on treatment, before you know whether things are working, you want to try and live as normal a life as you can without thinking and living your cancer every single day of your life. And I know it's hard because it's forefront in your mind and your family's mind, but it's really important. If you feel physically well enough, you should be living as normal a life as you can rather than waiting for things to happen. It's our jobs to look out for signs of resistance to treatment. Okay, so what this means is that in a vast majority of metastatic disease across the board, and certainly includes breast cancer, a drug treatment that is once working will most often at some time point stop working. That's not always the case. You know, I've got a lot of really long-lasting stories at 15, 17 years still on the same drug treatment and keeping metastatic disease under control. But in many instances, the cancer cell becomes resistant to the treatment. So it's not because your body is resisting the treatment, it's because the cancer cell is resisting the treatment. And there's a whole lot of biological mechanisms for that, and that is a huge area of clinical research. We do a lot of it based on, you know, the numbers of women who treat and the tumour samples that we have. A big plug for the Helen Sewell Tumour Bank. We're up to about 3,500 blocks now, so we have that many different cancers together with information on those women to actually be doing these kind of important biological studies. And then the last part of evaluating treatment is that it's a dynamic condition. So, and I know that this is one of the most distressing things, and it's often the hardest thing that I do in my job, is going through the process of having diagnosed metastatic disease and going through that emotional, psychological turmoil that causes the individual and their family, to plotting a treatment program, which often is a happy starting point because we're all geared now to do what we're going to do. Then there's that waiting period until you first evaluate whether the treatment's working, and that can be a bit of a harrowing time. And then you get the good news, it's working. It's a big sigh of relief, we all feel good, and life starts returning to normal. At the time point, your cancer becomes resistant to disease. I often think that is actually a tougher situation for you guys to handle than at the first time when you get diagnosed. Because there's all this disappointment and fear returns, the uncertainty of what does this mean? I got used to this drug, now I've got to think about getting another drug with all its side effects. So I understand absolutely it is a really trying time. This is something that I'm sort of trying to think about, how can we design ways of evaluating approaches that we can actually help you through at that time where disease resistance occurs. Haven't come up with anything brainwaves, very open to suggestions from the audience. How to treat involves going beyond treating the individual who has breast cancer. So I am very, very conscious about how a metastatic breast cancer diagnosis impacts on your children, whether they be 2 or 22 or 42. And I'll talk a little bit about how we've addressed this at the moment. But I think it's really important. I mean, you know your children better than anybody, and everybody is different. But my general rule of thumb that I try to advise my ladies is that it's really important, no matter what age they are, to sort of be open and transparent and include them and involve them in your journey. Obviously not to the point of scaring them, but, you know, the truth is they're going to know that something's going on if you're going back and forth from hospital having treatment. And it's better they hear about what your situation is than hearing it from school friends that said, oh, yeah, my auntie had breast cancer and she died, you know, or, yeah, my auntie had breast cancer and she was really sick. You know, if that's the first introduction to your children about metastatic cancer, it's frightening, and it's really hard to undo the impact that has. So I really try and encourage an early discussion about it. And then obviously the ongoing aspects of how you support your children is really important, and I'll talk to you about what we've done. Relationships, and this is with your husbands, your boyfriend, your mother, your sister, everybody. I mean, it often, I think I'm told by a lot of my patients that it really becomes an instance in life where you find out who your true friends are, who are people that you can't depend on, but equally those people that you can depend on. And I actually think that's a wonderful thing. You know, what more wonderful way to know who loves you best and who's got your best interests at heart. Yes, at a difficult time in your life, but I think that's a big plus of exploring the strength in your relationships. Employment. And this is an issue for some women. They may be the main bread earner for the family. They may be the single parent. They may have, their life is focused on their work, and to have that taken away is a bigger shock than being diagnosed with metastatic breast cancer sometimes. So this varies amongst people, but it's something, again, that I don't think there's a lot of research about it, and it's something that we hope to be able to address in some of the services that we've got, which I'll tell you about in a minute. Your living situation. So what I mean by this is support. Now, in a situation where someone has metastatic disease, there will be periods of times where physically and in practical sense, there will be a difficulty coping if you live alone or you live in a very isolated, unsupported sort of situation. So these are all things which I think are magnified in a state like Western Australia, because a lot of people are living in the rural regions. They may be separated from their close family living metropolitanly. And then there's the distance to travel. It's the cost of the distance to travel. So these are all things that I'm very acutely aware of. I don't know that I've got any answers about it, but these are all areas that, as part of a comprehensive centre here at BCRCWA, we're trying to address all those issues, provide advice, provide support, provide contacts to go back into your community so that you get those kind of supports for your living situation if it's an issue. And then I think one of the most important parts of treatment is giving or getting the right information. And I have to say to you, the one person, individual, entity that I probably dislike the most as far as breast cancer care is concerned is Dr. Google. I hate him with a vengeance, or her with a vengeance. And the reason is I'm not against freedom of information, easy access. I think that's all fantastic, and I think it's, all of you know the advantages of that. The problem, though, is when you guys search the net. And some of you, I know, are very selective. You only go to the MD Anderson website or the BCNA website, and then they have links to other things. And they're slightly better. But it's very, very difficult for you to read something which you think is relevant to you and know for sure that it's relevant to you. And the number of times I have spent time debunking something that one of my ladies was just so upset about because she read this about herself and she thought, this is me. I fit that mold. It's going to happen to me. And it didn't fit her at all. It was a completely different situation. Or you read something and it's a little bit out of context. So you think, hey, I'm on that drug. That happened, so that's going to happen to me. But what you don't understand is that patient involved in that clinical trial getting that drug had other factors going on, which doesn't become that apparent in a Dr. Google read. You don't know that. And so you don't know the whole story. So my take-home message is, by all means, do your own searching if you really want to, but you are in danger of getting the wrong information or the misinformation. So I always encourage you to, if you hear something, read something, discuss it with me or with the treating oncologist, discuss it with someone that you both respect, but also know that they've got the knowledge to address it. I've had patients come in and say, I love my GP, and the GP is really good, but the GP is a GP, doesn't know about breast cancer. And they make a comment, sometimes it's right, but sometimes it's way off beam. But because you've got a good relationship with your GP, you trust them, you believe it. So, if something is told to you and it doesn't quite seem right, or you think that's a bit strange, can you question it? And make sure you clarify whether that's true for you. And then once you know the truth, let it go. Please don't propagate the misconception in the community. Coming to that point, once you've had your lymph nodes removed from your armpit, it is absolutely safe to have a blood pressure cuff done on that arm. It's safe to have a blood test from that arm, and it's safe to have treatment in that arm. Full stop. There's a trial that shows all that. Of course, if you've had lots of lymph glands removed and lots of those lymph glands had cancer in it, you prefer not to put things in the arm, needles I mean, because every time you have a needle, it's not the needle that causes lymphedema, it's the risk of infection that follows the needle being puncturing your skin that gives rise to lymphedema. So if you've had that situation where lots of lymph glands are involved with cancer, you can still use that arm, but just the person doing the venesection has got to be very careful, and probably one of the worst propagators of this, you can't have needles in your arm, are the phlebotomists. And I've just found one here. on Friday, and I'm going to find her, seek her out, and tell her not to say that to patients anymore. Carmelo, remind me on Monday, please. And then part of treating is how to be the best support for your loved one. So now I'm talking to all of you in the audience who don't have breast cancer, but you have a loved one that does. And you're a really, really important part of the treatment team because everything you do, you say, and you don't say, or you don't do, can have a potential impact on the well-being of your loved one. And so on that note, I'll tell you a bit more about it as well, but we've set up, I think, a really exciting partners initiative. I can't get the guys to give a name to the group. I think some of you are in the room. So I want a name. I can't keep on giving it a different name every time. But at the moment, I'm calling it the Partners Initiative because I've been trying to set this up for years, and it's just happened now because I've got just all the right guys all at the right place. And what we want to try and do is set up a support group for the partners of patients with metastatic breast cancer to provide education, support, and a buddying system. Okay, a few special areas that I just want to spend a little bit of time talking about is how do you access the best treatment? Now, essentially, the best treatment is a centre that is able to provide evidence-based care. They follow all those principles I showed you before, confirm the diagnosis, evaluate the extent of the disease, look at the general health of the patient, look at the bigger picture of what's important to that woman's life and her children and her family and employment. And that's where the best access to treatment is. It's not any particular place. It's just any place that addresses the approach to breast cancer in that way. The second thing is cost of treatment. Now, in Australia, we're actually extremely fortunate. I know that often it gets into the press, woe be it, the government have not passed and there are drugs that we can't get. But can I just say to you, I give a lot of talks in a lot of countries. Australia has it really, really, really good. The availability for breast cancer treatment here in Australia is second to nowhere. And you often can't compare access to drugs in Australia to access to drugs in America because the healthcare system is completely different. So in America, most people, if they can afford it, have private health insurance. Private health insurance in America is completely different to private health insurance in Australia. The private health insurer, because the premiums are much higher, will pay for everything. And the bad thing in America is that the health insurance in America will pay for drugs that aren't even necessarily evidence-based for your cancer. So they have a way of saying drug A works for this particular type of breast cancer in this particular setting. The trial was positive. The drug becomes available. Then doctors can use that drug for any breast cancer patient anywhere across the world, in any way. And so you can't, never, never, ever compare what's happening in America to Australia. I think Australia does it really well. It's very scientifically driven. Yes, it's cost-driven as well, but it's cost-driven on a cost-benefit basis. And I think, there isn't endless money, and I think it's really quite acceptable and encouraging in Australia. I think education about unproven therapies. I do this a lot in my day-to-day conversation, and I still haven't got it right in terms of how I reach every single one of breast cancer patients around the world. Because unproven therapies, by definition, are unproven. Yes, they might be natural. Yes, they may be cheaper, although some of them aren't. Yes, they may have less side effects. But at the end of the day, and I hope you will all agree with me, if you have metastatic disease, your first priority is you want your cancer to be killed. You want it to go. You want it to be diminished. And so you want to take something that has that evidence proof that it's going to do it. And unproven therapies don't do it. That's basically what unproven therapies are. They give you anecdotal instances. It's not well-conducted, robust clinical trials. They don't control for other factors and attribute the benefit to just their intervention and not to other things. And one of the most dangerous things about patients taking on unproven therapies when they're having conventional therapies is the potential for interaction, where it can make you sicker, it can make your kidney affected, it can affect your liver. How do I prepare for giving you bad news? And there's no answer to that. It's not easy, but I think what I would say in as an encouraging way as I can is that when you've been diagnosed with metastatic disease, you are almost certainly going to be having a life of ups and downs. It sort of comes, unfortunately, with the territory of a disease that at the moment we can't cure in the majority of patients. So what I always try to think of is always look at the encouraging good aspects of your situation and the promise of what's to come based on getting evidence-based good treatment. Try as much as you can with you and your family to live as normal a life as possible, because if the breast cancer is constantly in your thinking, it's actually got your life gripped at a time where you're actually not dying from it, but it's got you in their grip because everything you do with your food, with your activity, everything you do is based on the breast cancer having an effect on you. So as much as it's practical, try not to allow that to happen. And I guess when there is bad news to come, often you get a bit of inkling at yourself, because most of you know your own body pretty well. You know how you've been feeling for the last 2 years, and if something has changed in the last 2 months, you often know about it. So in a sense, you're a little bit prepared. And my approach is, if I think there's bad news to come, or if I think there's a possibility of bad news to come, I always try to do it as quickly as I can, so I'm leaving you waiting for that news in the shortest interval possible. Now, I can't do that all the time because, sometimes they can't get the scan done until a certain day, and I can't see you for another 3 days, so I've got 3 days of waiting. But that's my approach. One of the things I try to do in a practical way is just try to shorten the amount of time you're waiting to hear the news. And then the second thing is that whatever bad news there is, I actually believe in breast cancer, there is always the next treatment or the next management approach. So once we've dealt with, well, how serious, how significant is the bad news, I then try to move on, well, this is the next program. This is the next way we're going to deal with it. And then, yes, you have to start lifting yourself up again, but that's how I think is often a way that I would try and encourage you to approach it. New treatment. I'm just going to talk about one family of drugs, because I know you love molecular biology, so I've purposely picked a really good picture for you. Okay. Now, many of you might have heard of this. I know that some of you are on these drugs. So this is the new kid on the block, which really is fairly exciting. So these drugs are called cyclin D kinase inhibitors. And essentially where they work, what this diagram is showing you is the cell cycle. So this is working within one nucleus of one cell. So what happens is it moves from this stage through a time of what's called G1, which is growth phase 1. For the cell to be able to start growing itself in this G phase, it needs to have these kind of enzymes. So the cyclin D enzyme joins with its partner CDK4/6, and when they join, they then allow the cell to move into the synthetic phase, the second phase, and then the doubling phase. So this was identified through really, really intensive research over the last 10 years in the laboratory, and was shown that if we can devise drugs that knock this off, we can actually potentially stop the cancer from growing. So that's really exciting. At the moment in 2019, these drugs are approved and shown to be effective in only one subtype of breast cancer, estrogen or progesterone receptor-positive disease. So that's why, those of you who are on it, that's why you've got it. There are now currently trials evaluating these drugs in estrogen-positive, HER2-positive breast cancer. Results probably be another 1 to 2 years away. These are the 3 drugs: ribociclib, palbociclib, abemaciclib. And these is really for the first time, all 3 drug companies got together, agreed that the end of the word would be cyclib, and actually formulated the beginning of the name of the drug in a way that I think you can pronounce. I actually think this is a relatively easy family of drugs to pronounce. I've heard all sorts of things, but anyway. So these are 3 different drugs from 3 different drug companies, but you can see that they're very, very similar in that they've all been evaluated in metastatic patient breast cancer trials of 1 to 2,000 patients. They all, with the exception of one trial with abemaciclib, gave these 3 cyclib drugs with a hormone drug. All right, and that's really important to know. So currently, the best evidence for the best effect is when you combine these drugs with another kind of hormone drug, like letrozole, anastrozole, fulvestrant. These 3 drugs are all tablets. So that's sort of one of the advantages. By and large, they've been shown to be effective in both postmenopausal women and premenopausal women, but in premenopausal women, they basically have to have had their ovaries suppressed to get onto one of these trials. That term I've used there, progression-free survival, means that for each of these drugs in each of these trials, they showed that when patients received these drugs in combination with a hormone drug, the women in those trials lived significantly longer before the cancer developed resistance and then progressed again. And it was a doubling. It's pretty consistent. All three drugs doubled the progression-free survival in those trials. Unfortunately, in Australia at the moment, the only drug that's available in PBS is ribociclib. And it is only available for women who have been just diagnosed with metastatic breast cancer, haven't had letrozole, anastrozole, or fulvestrant, and fulfill the other criteria of being estrogen positive, HER2 negative. So that's a very select group of patients who get access to those drugs. Palbo's not on PBS yet, Abema's not on PBS. They're all fighting and working hard to get themselves on the PBS. And we're really pleased to say that our centre has been involved in all clinical trials involving these drugs. So I have had the experience of using all three drugs. They have their pluses and their downsides, but it's really an exciting era of looking how we can use these drugs. And I've just put side effects in sort of lower print down there, but they're not completely toxicity free. So everybody thinks chemotherapy is the bad kid on the block, but these kind of drugs can have bad side effects, such as lowering your white cell count, rash, fatigue, diarrhea, and so forth. But generally much better tolerated than intravenous chemotherapy. So what are the issues? I've already spoken about the availability on PBS. At the moment, it's only available for first-line metastatic breast cancer. It's exciting that it's going to now be evaluated in HER2-positive disease. And probably one of the most exciting areas is that because of the vast improvements in progression-free survival in the metastatic setting, these three drugs are all now being evaluated for early breast cancer in a hope that it will improve cure rates. And again, we are absolutely delighted for me to boast that I'm doing all three early breast cancer trials. We've finished recruitment to the first, which finished last year with 5,500 patients. We're just coming to the end of the recruitment of the second trial of 4,500 patients. Then the third trial happened to be staggered to be opening in a few months' time. So we're going to be involved very much in knowing whether we can actually be helping ladies right now getting access to drugs that might actually be dramatically improving their cure rates, but at the very least, involving women in clinical trials that's going to make a difference for women in the future. The most important thing about these family of drugs is that they're pills. So the possibility of interaction with other drugs are very, very significant. And this is a whole new era which I won't talk about, but we're looking at programs of trying to educate GPs not to prescribe the wrong kind of drugs and making patients aware. Don't willy-nilly take things when you're on these family of drugs. Okay, blood tests. How many of you, can just raise your hands, how many of you have heard in the news about blood tests detecting cancer? Yeah, I thought so. Okay, so this is my 4-slide brief on it. So essentially, and it kind of makes sense, the cancer starts in the organ of origin, the breast. I've already shown you how when it becomes a cancer cell, it has the ability to get into the bloodstream. And therefore, the natural thought is, if it goes into the bloodstream, surely we can pick it up. So let me tell you where we are on that. The diagram below is an immunofluorescoscopy to show one breast cancer cell amongst a whole lot of other cells in the blood which aren't cancer. Now, to pick up this one cell, can I tell you it's extraordinarily difficult? And the problems about it is the detection method. There are a number of companies now that have actually created machines for detecting these, and they're probably going to be the big money makers of the future. But they're all a little bit different, but most of them share the common point that you send off a sample of blood and you get a result back as how many cells were seen in 10 mils or 100 mils. Now, the problem is that already research shows that when you look at the cancer cells detected in the bloodstream and then compare the features of that cancer cell to the primary breast cancer cell that was removed in the breast, in many, many, many instances, they're different. So that then instantly highlights a number of problems. If you're detecting cancer cells in the blood to use that as a means of detecting cancer and then treating it, if that circulating tumour cell is actually different to the cancer that's in the breast, which is metastasized to your lung and liver, there are big problems. You might not actually be hitting the right target. So a lot of research is being done to say, why is there this difference? The second area of interest is, are these circulating cells that we pick up, are they the cancer stem cells, which I'm sure many of you have heard about as well? And yes, some of them are, because they've got different characteristics. But again, we're years away in being able to identify a cancer stem cell in a given patient and then direct a therapy that will effectively kill that stem cell. So all of these are concepts, they're all rational, but they're not ready for prime time use by many, many years. So the irrelevance for use in 2019 is that they're not useful. I know that there are companies now, because I've had a few patients find it online and actually requested the test. I have no idea how much it costs, but they produce this result. They take a blood sample and tell you how many cancer cells in 10 or 100 mils there are. And the problem is that you can't use that information. You want to, but you can't. And so a woman that finds that she's got circulating tumor cells is instantly petrified. But what do you do with it? Because you don't have evidence. You know, in the absence of any secondary seen on scans, you're not going to give her chemotherapy and other toxic drugs because they're circulating tumor cells. So really, I'm not encouraging a head in the sand approach and say, forget about circulating tumor cells, don't order them. But I'm telling you, forget about circulating tumor cells and don't order them right now, because it's not going to be helpful. May be helpful in the years to come. Okay, so this is the best bit. What have we done in the last 12 months? Okay, so I've picked 2 trials that one is in the process of being published, and both of them in the process of being published, which I think will have an impact on what I do here at BCRCWA. I'm hoping when we publish it, it's going to make a difference to how other oncology teams treat their patients with breast cancer. So the first study is our multidisciplinary team study. This was presented by Amali Samrasingh, who is a third-year resident planning to specialise in internal medicine at the Melbourne International Joint Breast Cancer Conference in October of last year. So what we did was we recognised that in WA there are on average 1,800 new breast cancers diagnosed last year, and there will be slightly more this year as well. We know, and I'm hoping that all of you are familiar with the term multidisciplinary. Yes? Yes? Any? No? Okay, I see one no. Okay, so what multidisciplinary means is that you have a team of different doctors from different disciplines, and essentially that is, and allied health and nursing as well. So it's usually a breast surgeon, a breast oncologist, a breast radiation oncologist, a breast nurse, a breast radiologist, a breast pathologist. Sometimes you get physiotherapists, geneticists, plastic surgeons. Have I left out anybody? They don't often sit in the meetings, just because they're always operating. But we get it. That wasn't a criticism either. But you get all those people that I've just mentioned in a room, and we actually discuss your cases. And over the years, this has been clearly shown to improve a whole lot of things. You know, your patient satisfaction with your treatment, recommendation being evidence-based, and so forth. And so we're really proud to say we've had this going for probably since about 2001. So what we decided to do was that in 2005 or 6, I can't quite remember, I set up a system where we actually recorded everything about what we recommended for the patients to do. They're not all my patients. They come from all the people in our team, and we've got a big team within BCRCWA. And what we decided to do was we wanted to look at how good were we in conveying the recommendations to our patients, so they took it up, and we wanted to know who declined and why they declined. And then from a scientific point of view, I wanted to know whether if you declined the recommendation of treatment given to you, whether that would lead to a worse outcome. Because I expected that it would. No one's ever done this kind of prospective evaluation because it's quite hard to do. Unless you actually follow up and record everything, you actually don't get all the information. So what we did was, over a 5-year period, we found that we had discussed 925 patients. We had given over 2,600 treatment recommendations. By and large, the vast majority of the patients were women, which you would expect. And just to give you a rundown of what kind of patients were presented, so 2/3 of the patients we either presented or presented a number of times were early breast cancer. About 10% were women with locally advanced breast cancer. About 1/5 of the cases we presented were metastatic breast cancer. and then a very small number of women we presented because they had a local recurrence that required multidisciplinary input, and a very small number of women were presenting to look at whether their cancer led to being a genetically assessed need. So what we found was that the compliance rate with our recommendations was actually reasonably good. 98.6% of the women recommended for a surgical procedure accepted that. The results for chemotherapy, endocrine therapy, hormone therapy, and radiation therapy were above 94%, so pretty good. Overall, 92% of patients accepted what they were recommended, because some of these ladies were presented a couple of times, but 76 declined one or more treatment recommendations. And these were the reasons that they gave. And look at this, 40% declined treatment, both chemotherapy, hormone therapy, and radiation treatment, and Herceptin, because of a fear of toxicity. 30% declined because it was inconvenient. Now, I don't want to make that a little thing. Now, we categorize that as inconvenience when they said things like, it'll interrupt with my work, I'll have to take too much time away from work, I live too far away, and even with PATs, it's too disruptive. It's going to take too much time because I've got all these things planned, I've got trips and things planned, and my work is so important to me, even though I can take time off work, I don't want to, among the general rule. Does that surprise you? Yes. Well, you know, it doesn't, because this is what I hear. I see this. And to me, I think it's really sad when I show you some other data. So this is something I really want, we're really going to work on this evidence and actually try and change these statistics. And then about 20% of women declined evidence-based recommendation, despite their case being discussed by their doctor that they trust, I expect, and a group of colleagues that we all regard as highly specialized. 20% of these women declined because they wanted to pursue alternative therapies. Which, I actually think that is pretty good, because in other, this is just on 76 patients. I've got personal data that suggests the choosing alternative therapies might even be a little bit higher. Often the ladies who see me will choose an alternative therapy whilst they're doing conventional therapy. So that's a little bit different. But these are strictly patients who completely declined evidence-based treatment to pursue alternative therapy. So what happened? This is a chart of what happened to the compliant patients and the non-compliant patients. So 80% of the patients that were compliant with the treatment at now 5 years of follow-up are disease-free. So about 20% of them have had a local recurrence or a metastatic recurrence, compared to 63% have had an event. And in terms of now metastatic disease or death, about 20% of the women who were compliant have had metastatic disease recurrence, compared to 60% of women who declined treatment are either now dead or have metastatic disease. And that's where and this is the most startling part of the graph. And just taking you through the statistics, an odds ratio of an event means that women who declined treatment had a 6.5-fold greater likelihood of getting a recurrence or dying, and then dying of the disease. That's phenomenal. This would scare me, and I'm a breast cancer doctor. And I would hope, I don't want this to be a scaring fact, but it just goes to show that there is actually reason and rationale behind what we recommend. We're not trying to be, prescriptive. We're not trying to be bossy. We're not trying to be arrogant. We're just trying to recommend the best treatment for our patients. And it's really sad for me to see that when ladies decline, this is what happens. So we're going to get it published. We're getting it just in the point of submission now, so we're going to get this up and sort of circulate it for, probably BCNA and other people to know as well. So what we're going to do about it is that we're going to start utilising some of our new staff, which I'll talk about in a minute, to really identify these individuals right at the beginning when these recommendations are being made, and educate and support them through their fears. Can we just hold it and leave it to the end? Write it down. Thanks. We really need to do a lot better at educating unproven alternative therapies. But to be very honest with you, I do this all the time, and I struggle, because I don't know how to convince people not to do alternative therapy. So again, if you've got ideas, approaches, I'm really, really open for suggestions. And then I think, for those women who decline because of convenience, really in the healthcare system, with all that's available, we should be able to try and think of ways to try and help support them through so they don't not have treatment because it's inconveniencing. And as I said, we're going to make the rest of the community in WA and Australia know about this. The next thing, which is very dear to my heart, is our BCOS study, which is the breast cancer offspring study. So the background is that 49% of women diagnosed with breast cancer, so nearly half of women diagnosed with breast cancer are aged under 60, and just about a quarter are aged 50 or younger when they're diagnosed with breast cancer. So many, many, many of these women will have children in the age group between 14 to 24. And yet, despite the huge amount of data published on breast cancer, there is virtually nothing published on what happens to the offspring of women and men with breast cancer and what are their outcomes, what are their concerns. So I initiated this study in collaboration with Canteen last year. And what we did was we invited consecutive women with early or metastatic breast cancer to do the study. We approached 110 mothers, and between them they had 181 offspring, and for various reasons, either it wasn't suitable or convenient for them, we ended up with 74 mothers with 120 offspring between them. The majority were early breast cancer, but as you can see, about a quarter had metastatic disease. If the children were aged under 18, the mother had to consent to the child's participation. And a very good recommendation made by the ethics committee was, well, Arlene, what if you identify a child responding to your questionnaire and they're at a high level of psychological distress? So we wrote into the consent form, if that was identified, I was automatically notified and I personally contacted that child. So the results were about 60-40 girls and boys. About 3/4 were living with both parents. Just over half were either a single child or only had one sibling, and just under half were in secondary school, with the others either being in college, university, or working. And what we did was we utilised 2 validated instrument questionnaires that measured distress, a thing called a Z-score, and looking at unmet needs. This is a questionnaire that the Canteen group had developed. So let me show you the results. Alarmingly, 31% of the offspring recorded high or very high distress. And bearing in mind, 95 of the 110 offspring were women with early curable breast cancer, mothers who weren't, obviously, had gone through the diagnosis, but, everything was aimed for cure. Yet these levels of distress was found in these kids. And so 12 of the offspring I actually had to contact to offer psychology referrals if they wanted it. And as you can see, which is probably obvious, is that in the high and very high groups, there were more girls, more daughters who felt the distress than there were boys. The other interesting thing which I found was I'm just showing you the raw data of how these kids and young adults responded in terms of what they regarded as, I had this need unmet. And uniformly down through these lists is information. 70% said that I want more information about the side effects of what my mum's getting. 2/3 of them said, I want to know about my mum's condition, whether it's good news or bad news. I want to know whether there is recovery possible. I want to feel that my parents are being open with me about what's going on with their cancer. I want to know what happens when they come home from treatment. What do I have to do? And I want to know how the cancer impacts on my mum's life. So for those of you who have children, and I think maybe, I don't know whether any of you participated in the study, I think this is really important information to know, because, some of you may be very aware of this, some of you may not, and it says to me that these are all aspects of unmet needs that I, as the treating oncologist, and our team, we can actually do something about this. It's information after all. So as a result of that, we are going to start looking at ways of identifying the offspring sort of at the highest levels of risk of distress, and we're going to try and see what we can do to meet these unmet needs. And one of the interesting statistical findings was that the longer from that the study was done and the questionnaire was taken, that the mother had been diagnosed from breast cancer, whether it was early breast cancer or advanced metastatic breast cancer, the levels of distress were much lower, which I think is kind of good. It means that over time, the distress level does go down. And so we're going to be setting up a service when we have more room to be able to identify and design support programs. And also, I want to think about ways of how, a little bit akin to this, I don't know whether it's practical, that I can inform the offspring so they don't have these fears and concerns about what's happening to their parent. Very quickly, POVE study, vitamin D. Many of you know vitamin D is implicated in breast cancer. So the salient findings of this study, this was presented by Tricia Koo at the same meeting in Melbourne, and she won the Best Poster Award for this. So we were really pleased with that. The study showed that over 1,000 patients I've treated, the rate of severe vitamin D deficiency is 21%. But interestingly, women who had lower levels of vitamin D didn't actually have worse outcome. So when I ask all of you to take calcium and vitamin D, I'm not doing it primarily for your breast cancer, I'm doing it for your bones. We've also just completed, in the process of writing up, a biological study looking at immune cells, and I know immune therapy is a really hot topic, and that was the one question I got asked. But we have found that in a luminal B breast cancer, which accounts for about 55% of breast cancers, the immune cells don't seem to play a big part. So the hypothesis is that immunotherapies may not have as big a role to play in this kind of subtype of breast cancer, and that's sort of important information. And then lastly, the COLCAP study, we have published that now and shown that COLCAP can certainly lessen hair loss from chemotherapy. We've now shown which chemotherapies get the best results from COLCAP and which have the worst results. And so far, we've had over 150 women using the COLCAP, and I measured it for more than 1,200 times. So, that's a lot of cold heads. But I think, by and large, the vast bulk of patients, only 17% pulled out and said, look, it's not working well enough, but 83% of women really thought it was a worthwhile thing to do. So we're really, really pleased with that, and we continue to offer that as a service here. So just to sort of finish up a bit, I have 28 ongoing active trials. I've had the joy of working with Chris Loma, my fellow for the last 12 months, and he's now graduated and he's now an oncologist in his own right, and I think he's going to do fabulously, but he's going to be working with me half-time to help us progress some of these. So I've got lots of work for lots of people, and I'm really delighted that we've got a medical student and a neurosciences graduate, and I've got 3 residents. All have put up their hands to do some research with me, so I'm absolutely delighted. The more the better. And just to give you a look, out of the 28 trials, 16 of these trials are focused on metastatic disease. And that's something that we're really proud of, because if you look at major centres around the world, Memorial Sloan Kettering, MD Anderson, all those places, and you look at their website, the vast majority of those trials are early breast cancer or early preclinical data. So we're really pleased that we spend a lot of time looking at metastatic patients' needs. We've got 3 trials on immunotherapy. We've got 2 trials focusing on patients with brain secondaries that aren't amenable to surgery. And we've got 6 new trials about to open. I think I might stop. Do you want me to answer these questions? Okay. I just, if I've given you all this juice and excitement, I want you to ask me questions. So, if there are if you have questions, I'll just rush through these very quickly. I said I would mention this before. If you get told you have stable disease, can I please encourage you to be delighted and encouraged by that? I know it doesn't sound as good as remission, or it's gone, but stable disease is really good, because what it means is that the drug that you're on is working. It's not allowed the shadow, the lump, the mass to get any bigger. And that's a really good outcome, because your life, your survival, your health can't be endangered if those spots aren't getting bigger. It may take time, might be the next set of scans that shows that it's shrinking. How do we know if the treatment is working? I think I've gone through that, but I think, again, it's something that sometimes changes. So, for instance, in a lifetime of a patient with metastatic disease, you may have a very good sense, oh, yes, that result told me I was doing well, so I can trust it. 2 years down the track, the same scan may not be as useful as giving you that information. So as I said, metastatic breast cancer is a dynamic disease. It changes, the speed of it changes, so always be guided by what I and other oncologists say as to whether we think the treatment is working. Why don't cancers get eradicated when I know that there was a couple of stories in the newspaper the last 6 months showing how treatments had cured cancer in mice and in rats and things. And I think the problem is exactly that. You know, we're not exactly the same as mice and rats. I know you all appreciate that. But what you probably don't appreciate that when you do experiments in animals, it is completely controlled. So you have that mouse in the environment that you want it to. It can't expend more energy than it wants to because it's in that same cage every single day. It gets the food and the nutrition and the amount of water you want it to get. The way we conduct clinical trials in animals is that we inject cancer cells into usually the hind of the mouse or rat, watch it grow, and then you give the treatment that you're trying to give. Everything is controlled. The other thing is that when you give treatment to a rat, it's not being interfered with because they're on alternative therapies, concomitant meds, a little bit of alcohol, a little bit of this and that, right? I can guarantee you we don't give rats alcohol. So when you measure the results of what happens in that rat, it is so pristine and so controlled, it probably doesn't surprise you that it doesn't immediately translate into the human because we're much more complex, stating the obvious. So, you know, I think it's good that the journos want to give a bit of encouragement, but let's be honest, a lot of times it's just selling papers. If you put an exciting story, you leave out bits and pieces, it sells more newspapers. So you've just got to be very mindful how you read these stories. And then why does treatment that was working suddenly stop working? That is a lecture of about 10 hours to just touch on the topic. The short answer is that the cancer cell has the ability to push out drugs that got in and killed initially. It can push it out. Cancer cells can block drugs getting in where it initially got in. Cancer cells can say, okay, I'm being stimulated to grow by pathway A. I'm going to switch that off. I'm going to grow on pathway B. Funnily, the drug only blocks pathway A. So therefore, it happily grows because it's now being driven by pathway B. And there's multiple other things. We know that the surrounding cells of the cancer can help promote cancer growth. We know that immune cells around cancer cells can promote cancer growth. It can kill cancer, but it can also promote cancer growth. We know blood vessels around cancers can help cancers grow faster. So there are a whole lot of reasons why that last statement works. And you've got to figure what is the most relevant in that patient that's in front of you. Okay. Interesting and exciting stuff for me to convey. We have 4 new staff members since last year. 2 girls, Tiana and Cynthia, are working within BCTU. Stevie, who I think is here. Where is Stevie? Is Stevie here? No. She set all this up. She's our new project officer. And then we've got Kath Griffiths, who is one of our 3 breast cancer nurses. We have 3 full-time breast cancer nurses, and I'm absolutely delighted. Between them, they will manage patients right from the word of diagnosis through surgery, through adjuvant chemotherapy and metastatic disease. And I know many of you have known and met and been supported to a huge extent from Amanda, who is sitting up the back. We have new partners. I wanted to name names, but Carmel said no. But it's exciting. We've got a lot of people. I've just got another law firm that wants to help raise money for us. We've got some sporting groups, which I think is fantastic. So, you know, it's wonderful to be seeing so many businesses in the community engage. We know that breast cancer is the most supported cancer in the world, particularly in Australia. And it's just fantastic that after all the hard work done by our team and, you know, Carmelo and the group, that people now know what we do. We add to all the other services that's around. We do things a little bit differently. We have a different focus. And there are now a number of businesses and groups that want to collaborate and support us, so that's fabulous. I am completely overwhelmed with the ongoing work that you guys do, and those of you that aren't here, but those of you that will hear me through the website, that support us through your fundraising endeavours. And just to name a couple that are happening, the Something Pink, the Raising Hope, and the Italian Club are going to run a couple of fundraising dinners for us. So I am absolutely, thankful and grateful for that support, because without what you guys do, we can't keep on investing back into doing the research that I do. And then, this is the as yet unnamed group for partners. So some of you are here, but, look, guys, if you think you want to be involved, then just all you have to do is just give me your name or give Carmela a name. There's a whole lot of activities being planned. Part of it is going to be information as well, and no doubt Carmela will find an excuse for me to talk to them and have something else like this. Yeah. Okay, not straight after this. So that's something I really want to promote, and we're going to try and encourage this group to really grow and both be a support to the partners as well as to allow the partners to be better supports to their loved ones. And then this is our new building. And I want all of you to promise me that if you're not away or you've got other things, that you will come when we have the opening. I don't know when it's going to be. I'm hoping it's sort of first quarter, early second quarter next year. That's me there. Is that me? Is that me? Or is that me there? Maybe I'm that one. And you notice why I'm pointing to it. It's got a window. So we are so pleased that Ramsey has come to support us. So it's going to be fabulous. We'll probably be occupying about a third or half of that top floor. You're going to have a state-of-art radiation oncology service down here, and a state-of-art radiology service. All one shop. We're going to have all the people that need to help you, guide you, support you in one area. So I'm expecting a big party that day. And I'm going to talk for like 2 minutes. And on that note, I'm going to stop because I'm running out of breath. And okay, so Simon is poised for you to put your hand up and ask me questions.
This is the first time I've been to one of these. Are you going to do something like this for early breast cancer patients?
Yeah. One of the problems with it was just my time, but I guess also secondly is where the early breast cancer patients are on their journey. Because a woman newly diagnosed, just about to start a chemotherapy, is somewhat different to one that's just finished, still going radiation and so forth, to someone that's sort of 3 months after. But we've already had a discussion with Kath and Dawn, and we're going to set up some... And I guess to make it worthwhile, as is for this meeting, it's not going to be confined to just people who are treated here at Hollywood. I really want to make this something that's worthwhile and meaningful, for women and men with breast cancer. So... we'll probably look at something later in the year, maybe around October, Breast Cancer Awareness Month. But yeah, that's the plan. There was just one second. Yes.
You're pretty adamant about where you stand on therapies, and if it's not, evidence-based, you don't want it anywhere in the room with you. However, you do say that you have patients that sort of do some alternative or complementary therapies. Let's use the word
complementary, yep.
Rather than alternative, because there's a difference.
Yes, completely.
And then we'll do, the conventional as well as some complementary therapies. Now, how do you deal with that? Because now the beast is in the room.
I think good food and good nutrition is important. What I don't want to do is I don't want to have people on complementary therapies that might interfere with the effectiveness of the drug they're on. So, complementary therapies, which I'm absolutely okay with, are vitamins, okay, at reasonable doses. Any kind of nutritional supplement, which is you make in your Vitamizer, your smoothie, the way you cook things, I have no problems with that. And the reason is, basic physiology tells us that when you ingest something, unless it's actually formulated in a way to overcome the absorption mechanisms in your gut, your body will actually only absorb what it kind of needs and what it wants. So I know that I can almost safely say that there's very little that you can ingest in terms of vitamins and minerals that could harm you. unless you're swallowing buckets of nails and heavy metals and all that kind of stuff. So food, I don't have any problems with. The problems I have is when people show me bottle after bottle of supplementaries that have some herbal components, some plant derivatives, and specifically elements that are acting as antioxidants. Because, just very briefly, there is some evidence that antioxidants, if you think about it, you're using antioxidants to protect harm and damage of the conventional drugs on your normal cells. Why wouldn't that antioxidant protect your cancer cell and stop it from being killed off by your conventional drug treatment? I just don't want that to be a possibility. And so what I also find is in many of the supplements, they overlap. So one bottle has 200 milligrams of calcium, the next has 50 milligrams of calcium, the other one has enough. And so you may potentially be having excessive amounts of elements that are dangerous to you. So when I start looking at blood tests and liver function and kidney function, I start seeing things going off. If I've got a patient that's taking a lot of supplements, I actually don't know. Is it because my drugs are causing harm? Is it because the cancer's causing harm? Or is it because of an interaction? So foods, I generally don't have a problem with it. Vitamins, I don't have a problem with it, except for intravenous vitamin C. And vitamins such as, there used to be a time, and I don't know whether it's a big thing at the moment, but people infusing Laetrile, which is big in Mexico. And there's been one death from it in Australia, so in WA. But I think oral intake of things that you prepare, I don't have a problem with it. If you're doing complementary therapies like Reiki, hypnotherapy, music therapy, anything, massages, I don't have a problem with that because it's not going to cause harm, it's not going to interact with the drugs that I'm doing, and if it makes you feel better, I'm all for it. There was one question that Vanessa gave, but I don't know what the question was.
I've been hearing more about immunotherapy in the press of late. Can this form of treatment be used in treatment of metastatic breast cancer? What other treatments are available besides chemo, surgery and radiation? Okay. So to answer the last question, so the question was, is immunotherapy useful for treating metastatic breast cancer? And what else is there available besides chemotherapy, radiation and surgery? So the last one is there's hormone therapy, but this is obviously only effective in women with hormone-positive breast cancer. There are biological therapies, and that I mean ribociclib, palbociclib and abemaciclib. So those are biologics. Immunotherapy currently has some indication in triple-negative breast cancer. There's one trial that's been presented suggesting that it might be beneficial, but it's not available in PBS, and it has to be duplicated that it's actually going to be effective. In estrogen receptor-positive breast cancer, as I indicated to you by the trial that we did, immunotherapies aren't being evaluated very much at the moment. HER2-positive metastatic breast cancer patients are also, there are some trials that are evaluating immunotherapies. So although immunotherapy has certainly improved the survival and life for patients with melanoma, some forms of lung cancer, its role in breast cancer at the moment is still very, very small. So again, it's a little bit of, incorrect media hype about how effective these drugs are that sort of falsely raises the hopes of patients with breast cancer, but not quite yet. But in the future, I actually think there may be a role, but it'll be in a very selected group of patients.
Can I ask a question? The new center, is that going to cope with the treatment that my daughter was having, or she still have to go to the main hospital?
No. So this is going to be on the other side of the building where the chemotherapy ward is now. So Starcevich will still run, and this building will be behind it. It'll be a short walk. I imagine it's going to be a similar kind of walk as from my rooms now, or maybe a little bit further. Yeah. Yeah, it's not practical because, there are other patients that require chemotherapy. We thought about that for a little bit as to whether we would actually treat all breast cancer patients within the centre, and I didn't think that was actually very practical. You're doubling staff, you're doubling the risk of, delays and drug delivery and all that kind of stuff.
Is there any scientific evidence that you are aware of about the dietary recommendations, like dairy or meat?
Okay, good question. Thank you for asking me that. So the data that is positive, that is evidence-based, is that excessive amounts of unsaturated fats and often that's found in a lot of meat, can be detrimental to prognosis. Patients who drink a lot of alcohol, and by that, and I know you all grunt at me when I say this, it's less than 3 or less drinks a week can be associated with a worse prognosis. And really a diet that propagates obesity. Obesity is a bad prognostic factor. So can I please lay to rest, as much as the needle in the lymphedema arm, sugar, eating it, having it, does not grow your cancer. So I don't want you to get bad teeth. I don't want you to be overweight from too much sugar, but having a bit of sugar is perfectly safe. I really cannot understand how this has been blown out to such a huge degree. It just doesn't make even physiological sense. Dairy products is more about, I think, the fat content, because really, you know, as far as we know in Australia, the use of hormones to stimulate, you know, cow's milk and all that has been regulated. And so I think a lot of women choose not to have dairy products after they're diagnosed, but that's their choice. Soy products is perfectly safe. And it's wrong if you have too much soy that it's bad for you. Too much of anything's bad for you. But if you want to substitute dairy milk with cow's milk with soy milk, that's perfectly fine. So for Judy's sake, I'll just say this again. 3 drinks, standard drinks, right? Not 3 drinks like that. 3 standard drinks or less a week. Yeah, but is it like 100% vodka or? Who asked me that? It is evidence-based to a degree. And I think it comes down to also a little bit of a guesstimate, because I think for those of you who know about alcohol metabolism and all that, there is a difference. You know, we even know between men and women, they metabolize alcohol and its byproducts differently. Ethnicity, you know, Asian people metabolize alcohol differently. So yes, it's a generalization. More of that comes from colorectal cancers, but it seems to be sort of the kind of ballpark that you would be aiming, because you know that whatever you say, patients are probably going to go a little bit above it. And look, it's really hard. It would be impossible to do a randomized trial, because then you'd be forcing some people that don't drink alcohol to drink alcohol and vice versa. It would never work. But there is some evidence behind it.
What about prevention education? As in, I know that's a very broad subject, but as to, you know, why are so many women getting it, and is there something like evidence-based?
Yeah, there is. And I guess there's a lot of factors that feed into a woman's risk of getting breast cancer which you cannot change, i.e., when your menstrual period starts, right? Whether you carry a gene that was passed to you by your mother or your father. But the lifestyle changes that has been evidence-based to show to lower your risk of breast cancer is keeping a good weight, not having a prolonged exposure to outside use of estrogen, and by that I mean prolonged uninterrupted use of the oral contraceptive pill or prolonged use of hormone replacement therapy. Interestingly, there's been a study that was published last year that showed that women who had IVF, so a lot of estrogenic stimulation, are not at a significantly higher risk of getting breast cancer. So that's thought to be safe. Exercise, which I think often goes along with lack of obesity and lower fat diet. So all these are generally correlative factors, but exercise has been suggested to lower the chance of getting breast cancer and improving the prognosis of someone with metastatic breast cancer or early breast cancer. And in some women who have very high risk of getting breast cancer, there is evidence from 3 trials that shows that tamoxifen or a drug called anastrozole can be used to help prevent getting breast cancer. Yep, good question. So those are estrogen. The question was, how about Vegifem or Ovestin cream that you apply to the vagina for vaginal atrophy symptoms? So there's actually a trial that's going on in America. It's recruiting really slowly. But to date, there isn't any obvious evidence that use of topical estrogen, number 1, causes breast cancer. Number 2, worsens your metastatic breast cancer. But generally, that will also be dependent on whether you've got a triple negative breast cancer, which is not stimulated by estrogen we think, and also whether if you have got an estrogen-positive breast cancer, are you actually currently being treated with tamoxifen? Because tamoxifen is an estrogen blocker. So if you're on tamoxifen and you've got terrible vaginal symptoms, I will often advise my patients to try using Ovestin or the low-dose Vegifem cream, not the pessary, to improve vaginal symptoms. Remind me when next time. I'll see whether you want to go into the trial. We've got an exercise trial at the minute because, as was asked the question by Jessica, is there an exercise program available for metastatic patients here at Hollywood? There is within the physio to be talked about exercise, but there isn't an actual program. We can certainly refer you to other places in the community, but we've actually got an ongoing trial called the AREA trial where ladies with metastatic breast cancer are being randomized to either a 6-week exercise program being done at a physiotherapy practice that we're working with on Sterling Highway, so just around the corner, or the control arm. And you do 2 sessions of exercise a week for 6 weeks, and we measure how that helps with your fatigue as an endpoint. And then if it's working and that exercise is good, what the physiotherapist does is basically teaches you to do this yourself, either in your local gym or at home. Remind me, I'll talk to you about that. Yeah.
What about a state of mind and education and health with the brain and educating, sort of making sure that people are healthy upstairs, being able to tolerate good news, bad news, deal with drugs, the brain being able to trick the body into, healing, meditation, all that kind of stuff.
Okay, so the first thing is the question that was asked was what attention has been made to the mental state in terms of dealing with decisions and stuff, but you also talked about the blood-brain barrier, about how things can get into the brain as to whether that makes things better or worse. So as far as the brain is concerned, I absolutely am convinced that your mindset of the patient and your loved ones as to how you face your illness has a huge impact on how you do. And I don't think that probably surprises any of you. I think if you feel well informed, if you know what the treatment plan is, what the expectations are, what the goals are, and you feel well supported and comfortable and nurtured, I actually have no doubts that person will do better than someone who says, I don't understand anything, I don't know why I'm doing this, I don't know what we're aiming for, I feel so stressed at home, life is so difficult. I think those outcomes will be completely different. So we are trying to very much have counselling and clinical psychology as part of our new centre. We do that on a one-to-one patient basis in terms of who needs it and so forth. In terms of the more interesting question, which is, can we actually do something that improves your mental attitude? That would be really fabulous. I'm not quite sure how to design that trial. Because first of all, I've got to either eradicate 40 years of attitude and behavioural changes in that person, if they've got the wrong attitude, or do nothing for the person who's got it all right. They know everything, But no, I absolutely believe, which is why I do these kind of talks, because I'm really hoping when you have good, real, understandable information, it's power. It gives you peace of mind. It gives you understanding. And hopefully that makes it easier for you to deal with whatever you are in your journey. The blood-brain barrier is a big area of interest for me. It's probably too early to talk about it, but we're in discussions with setting up a national program. But the problem is that for purpose of your brain health, the blood supply to the brain is actually quite different to the rest of the body, which is a way of your body being protected against a lot of the chemicals and things that you have. Now, unfortunately, that happens so that if cancer gets into the brain, the drugs that I use to treat cancer outside the brain often doesn't get in there. And that's a big problem. Because depending on what kind of subtype of breast cancer you have in the metastatic setting, as women are living longer and better lives because the cancer is being controlled, the rates of the cancer travelling into the brain are slowly increasing all around the world. And we really don't have a lot of very effective treatments. So, I'm absolutely delighted. I've got 2 clinical trials that only involves women with tumours that have spread to the brain. And there's a lot of research being done around that area.
Arlene, can you just talk a little bit about what happens in a clinical trial where people are getting the placebo drug and if they're obviously deteriorating? How do you handle that?
Yeah, so trials that have a placebo are done essentially for 2 reasons. The first reason is that you know that the active drug you're evaluating has side effects. And you're thinking it's going to be so effective, it's going to be the next sort of, standard of care drug. But you want to be able to understand what the real side effects are. So one of the roles of the placebo is to work out exactly what side effects are attributable to the active drug and not the placebo. And you will laugh or fall off your chair when you see the numbers of trials where the women are getting sugar pills and they have an 80% severity of hot flushes, 80%, and huge levels of side effects. They know because they were in a trial. They told, if you get the active drug, you're going to get sore joints, nausea, and headache. And the number of women in the placebo arm that complain of that, it's phenomenal. So the placebo drug is actually quite important in trying to understand what the real side effect profile is of an active drug. The second reason why a placebo drug is used is that sometimes if, as the treating doctor, you know your patient's in the trial and you know the patient's getting the active drug and patient B is not getting active drug, you don't want to be, you're not being manipulative, but you know that information. So when patient A walks in, they're on the active drug and they say, I've got a sore leg and I'm a bit more nauseated. You will almost certainly say, okay, it might be the drug, it might be side effects, and let's deal with it. If patient B comes in and says, I've got a headache, I've got a sore throat, I'm more nauseated, you think, could you be progressing and could you be having brain mets or something else going on? So there is a tendency that if the treating doctor knows whether the patient's on active treatment or not, we respond in a slightly different way, and then that influences the effectiveness of the drug. So patient A, you don't recommend to do a brain scan because you say, oh no, that's explained by the drug because you're on the drug. Patient B, you say, oh, you're not on the drug, I can't think of any other reason, I'll scan you. So then you find that this patient has got a disease. Now, this patient might have disease as well, but you haven't done the scan. So it makes the results biased. So one of the reasons they introduce a placebo is to avoid any kind of bias so that at the end of the trial, when the results are presented, hand on heart, with all robustness, you can say to the community, it was the benefit for the drug that improved the outcome or the side effects were due to the drug. Now, if someone deteriorates, I don't know they're on placebo. So if you're in a trial where there's a placebo, the trial will always mandate the same regularity of assessment. So that means the placebo patient, if they're on placebo, is not having any detrimental effect. Each group are going to be scanned every 6 weeks or 9 weeks, going to have the same kind of scans, you're going to be done at the same time, going to have the same kind of blood tests. So if you're deteriorating because you're on the placebo or you're deteriorating because the treatment isn't working anymore, I'll know about it. Once I know about it, take you off trial. That's always the ethical thing to do. I knew you'd like that.
Why is ribociclib linked with the hormone drugs if its role is just to inhibit cell division?
Because the estrogen receptor, next year I'll do a more complicated diagram. Just for Simon. Okay, so this is just focusing on the nucleus. This is all going on in the nucleus. Within the cell, in estrogen-positive cancer cells, the estrogen receptor, when it's stimulated, it comes in and it actually interacts with this. So the reason why all the cyclips are being paired with a hormone drug is because you're trying to knock off the estrogen stimulation pathway. So it's combating both points. But I think if you picked up on this study in abemaciclib, it's the only drug that they did in a small several hundred trial where it actually worked as a single drug. So the company might be, when they're trying to get it in for registration, a bit different to ribo and palbo. They may actually try to get an indication for it to be used as a single drug after first-line metastatic disease.
My first line of treatment was letrozole.
Yep.
And burned through that one. So if I went on ribociclib with letrozole, would that work together? Does that have...
Yeah. That probably wouldn't be what would be recommended, because having said that, there are now trials looking at patients that have been on ribociclib and letrozole. The cancer progresses, they continue on ribociclib, and letrozole gets switched out, right? Because they think ribociclib might have a role. But if you flip it the other way and you've been on letrozole and it stops working, there's no strong data that adding ribociclib necessarily will change it. It might, because sometimes it might be that your cancer has been so well suppressed and killed off by the letrozole, it's very, very sensitive to it, and just a few of the cells have developed the CDK pathway. So you could, theoretically, continue on letrozole and just add a CDK inhibitor, but you won't have that ability to do anywhere in Australia because you wouldn't get access to it. The more sensible thing to do would be to, if you're progressing on letrozole or anastrozole or exemestane, is to stop that drug, get a CDK inhibitor, and then get it with another hormone drug called fulvestrant. And I've got quite a few patients on that, and that works really, really well. So it's what it's called, it's from a family of drugs called SERDs, and it's a selective estrogen receptor dysregulator. So what it does is when it gets into the body, it finds an estrogen receptor cell, and it actually latches onto the estrogen receptor and it degrades it, which is different to tamoxifen, which occupies the receptor and stops it from working. Now, you might be pleased to know we've just been approached, and I'm actually in a meeting with them next week, to do a new trial of a drug like fulvestrant, but it's an oral form. I thought that would make you happy. So we're having discussions with them next week, so hopefully we're going to get the trial up and running in about 3 months' time. So I'm really excited. If we are one of the first sites to identify this drug is effective, and we can roll those results out through really quickly, it'll be a huge advantage to women with breast cancer, because we know that fulvestrant with each of these cyclips is a really active combination. 2 problems. One is the injection, it's a bit uncomfortable, but 2 is you can't get fulvestrant, it's not on the PBS. So it's only available, as you know, either on a hospital formulary or in a access program, which is a bit tricky because women still have to pay $3,700 of treatment before they get full access to the drug ongoing. Any other questions?
Just not the list at the moment, sort of in the future. Where's everything trending towards cure and all the rest of it? Are we going to be, walking through museums and saying this is how patients were treated on chemotherapy, radiology? What's your thoughts?
I'm going to be honest, but I'm also going to be sort of realistic. I think we are working really fast at improving the cure rates, but just remember, cure rates have the highest chance of being cured when women are diagnosed with early breast cancer. So that study I showed you where women who declined treatment did so badly, we've got to stop that from happening as much as we can. At the end of the day, a person is a person, they make their own choices. But, I think if we could overcome some of the barriers and help those women get compliant treatment, we'll increase cure rates. What you're probably talking about is curing the individual. And I think we've got a long way to go. The problem is that, besides the complexity of the cancer cell, it is getting the drugs to the areas where the cancers are. So a woman who has one cancer metastasis in the liver is more likely to get the drug into it than if it's in every single part of the body, including the brain. And so therefore you can't generalize, what the curability of those patients are because it's so disparate. And, I think we're working on the right link. We're looking at genes. We're looking at understanding the behavior of cancers. This is all being done in parallel with education, screening programs for early breast cancer, all those things. So I think a lot of people are doing different things in different arena, all with the same goal of trying to eradicate cancer. But I think we're a long way away from it, certainly for breast cancer. Okay, we did another study that Chris presented in Melbourne, and that's about to be published. We looked at just under 100,000 breast cancer cases in Australia. It's going to be the biggest study in Australia ever published over the last 10 years. Males with breast cancer constituted 0.6%. So they're really small numbers. And essentially, a very large proportion of males have estrogen receptor positive cancers, and so they are treated in line with what we would do in treating a woman with estrogen receptor positive cancer. And then if they have triple negative breast cancers, HER2 positive breast cancers, we apply the same treatment. And, you know, there's no biological or physiological reason to think that they're going to respond differently. Okay. I really didn't think we had 2 hours to talk about, but we did have 2 hours to talk about. So I think, okay, just to remind you, we have tea and coffee in the back room. So please, if you just want to talk to people that you've met, step in there and avail yourself to that. Thank you to Stevie and Carmelo and everybody else that helped, and Amanda and Anne, I couldn't see you, and Anne, for organising today. Thank you for coming, and as I said, I hope you propagate all this information out in the community, okay, so that everybody gets the right information about breast cancer. Okay, you're welcome.